She is with the Center for Advanced Heart Failure Care at Hahnemann. I met her over there at one of the Second Chance meetings, and she has graciously come to talk to us about her background, which is in pharmacy in the transplant world, and she has picked a title that speaks to some of the complication issues of pharmaceuticals. Feet don't fail me now, and everybody before has said something like, that's why I'm here. I want to hear about this. So, Grace, with that, I know you've got a slide coming up which talks about your background, so do you want to just move to that and talk to that?
All right. Well, I just thought I would start with a short, the reason why I thought of this, I was talking with Teresa Rowe, who's the former transplant coordinator at the Center for Advanced Heart Failure Care, and that's part of Hahnemann Hospital, Drexel College of Medicine. And I said, what would be a good topic? And she said, a lot of people that she's talked to really struggle with trying to manage gout, and in trying to put together some things, I thought of the theme. And there's, if you're a fan of New Orleans music, the New Orleans musicians, they sing a song, "Feet don't fail me now, feet don't fail me now." And so that's why we're here tonight. And I thought there's a lot I would like to share with you tonight, with people, especially with gout. If you have had a transplant, you are at higher risk for developing gout. In the general population, across the United States, the incidence of gout is about 1%, but it goes up to about 30% if you've had a transplant. And the flip side, at the end of the presentation today, I'll talk about diabetes, and two of the important things that you really need to be aggressive with are diabetic foot problems and also peripheral neuropathy, which occurs in people that have diabetes and also people that have had a transplant. So I've been at the Center for Advanced Heart Failure Care since 2001, and I teach at the Philadelphia College of Pharmacy, which is now part of the University of the Sciences, and we're in West Philadelphia. So every year I get pharmacy students that come to the center, and I'm really interested in thinking about medications. We get a lot of questions about drug interactions. We get a lot of questions about, could this be a side effect or a different medication. So we're always busy doing some research. So I thought I would start out with just some quiz questions to test your knowledge. What president's wife was notorious because of a closet full of shoes?
The one in the Philippines?
Imelda Marcos. So when they overthrew the government and went in, she had 3,000 pairs of shoes in her closet. Which artist from the Renaissance called the foot a masterpiece of engineering and a work of art? Leonardo da Vinci. And gout is known as the disease of kings. Can you name any famous people that are known because they had gout?
Henry VIII.
Henry VIII? You. Everybody here? Ben Franklin, we're right down next to the kite. Charlemagne, Charles Darwin, so a lot of people have had that. And we'll start out talking about gout, and it affects your feet. I think we need to have respect for our feet. At the end of our lives, we'll probably have walked 100,000 miles on our feet. We've got 26 bones in each foot. Every time we run on our feet, the force that we exert on our feet is about 4 times the weight of your body. So our feet are under a lot of stress. And with gout, it's a metabolic disease, and it involves uric acid, which is a normal chemical in our bodies. And I'll talk to you a little bit about what we know about transplants and the gout. So the problem is that this uric acid, which is normally found in the body, something triggers it, and it forms needle-like crystals. Those crystals deposit in the cartilage and the synovial fluid. The synovial fluid is the fluid around your joints. And it can also deposit around tendons. It can deposit in strange areas. There can be little deposits of crystals that form on your ear and around the cartilage. The deposits are formed around the olecranon bursa, which is in your elbow. And normally when you eat proteins are broken down into purines. purines are eventually metabolized to uric acid. So it's a normal process, but something happens that triggers the change. So if you go to your doctor and you get your blood drawn, they're going to measure your uric acid levels, and these are 7 milligrams per deciliter or less. That's what our normal level should be in a male. And for women, it's a little bit lower, less than 6 milligrams per deciliter. Now we know that uric acid levels definitely have something to do with gout. If your levels are between 7 and 8 milligrams per deciliter, so just a little bit higher, there's an incidence of about 0.5% chance that you can get a gout episode. But if your levels are higher than that, up above 9, it jumps from 0.5% up to about 5%. So the higher your uric acid levels. Now, I'll talk a little bit more about this, but a lot of people walk around and they have very high levels, but they never get a gout flare. So there are some people that have asymptomatic hyperuricemia.
Grace, let's ask the question of this particular audience. How many have experienced gout in their life?
I still do.
Okay.
Yeah.
That's 80%.
Yeah. So we'll have to figure in some other things that are going on. If you have hypertension, if you have kidney damage, that also factors in as a risk factor. And in individuals that have a liver transplant, you're usually less likely to have gout as compared to individuals that have had a heart transplant and a kidney transplant. And it probably leads back to the fact that people with kidney and heart transplants usually have the other risk factors like hypertension and chronic kidney disease. So gout, it's usually eliminated by the body, mostly through the kidneys and somewhat also through your gastrointestinal tract. Okay, so here's your anatomy of your foot, and your ankle is here, and then the mid bones in your foot, these are your metatarsals. Your toes are the phalanges. So at this joint, when you have the metatarsal phalangeal joint, we call it the MTP, this is often where the gout crystals will form, and you'll have a lot of different symptoms. Now, if they found that in individuals that have had a transplant, sometimes you get gout in places that are a little atypical. Now, many people without transplants will have this MTP, or the big foot joint gets inflamed. But it's also occurred in the backbone, the sacroiliac joint, and also in the spinal column. So some atypical presentation. But this is the picture. This is the MTP, the big toe. You can see it gets red and inflamed, and this person's also suffering from some ankle pain as well. And this is a picture from the American College of Rheumatology, and they also have a lot of good information for you as well. So there's a spectrum of what's going on in gout, from an acute phase to a chronic phase. In the acute flares, and I'm sure you can tell me more about the pain and the redness, but at a certain point you can have these tophi, or these crystals form. They form nodules. If they form in one joint, it's called monoarticular tophi. And over time, it can affect many of the joints, and you can have polyarticular tophi. And the chronic problem is that they can destroy the joints, and you can get flares, many flares. I didn't download the pictures from the American College of Rheumatology, but there are a lot of pictures on the internet which show more detail about the chronic changes that happen to the joints. So the tophi, once again, this is a nice term to know, the tophi. This is if you look at someone who's had chronic gout over a number of years, it actually looks like a nodule over the joint. And when the doctor will diagnose it, they'll go in and they'll tap that joint, they'll collect the synovial fluid, and they'll look for the presence of these crystals under a microscope. Now, gout can sometimes appear to be, can be confused with some other conditions, so they have to be careful when they diagnose you. Oftentimes they'll also culture the fluid that they draw out, because another thing that's similar is septic arthritis, and that's an infection affecting your joint. So they want to make sure that you have gout and not a septic arthritis. But people that have rheumatoid arthritis, sometimes that can appear to be the same as gout. lupus, and also psoriatic arthritis. Anybody's a golf fan? Phil Mickelson is on the TV recently. He's a golfer, and he's been advertising for one of the drugs for psoriatic arthritis. But also, all of these can mimic gout. So your doctor's going to want to make a differential diagnosis there. So the joints that are affected, why is it occurring in your toes? It also can occur in your hands. It's because they're areas that are far away from your heart. They're in low blood flow areas. And I'm sure, so it can affect your skin, your tendons, your cartilage. And I was talking to Bob earlier, and he had mentioned when he gets a gout flare, the medications work very quickly. They can resolve on their own within 3 to 14 days, but during that time, you're going to have to put up with a lot of pain. So later on, I'll talk about some of the medications that can be helpful. Okay. The other thing in people that have had transplants, as compared to everybody else in the country, generally the tophi, when the tophi, these nodules form, generally it takes about 5 years of having high levels and having your gout flares, and then after a long time, after 5 years or more, people will develop the gout. But people that have had transplants, it can happen much sooner than that. So that's another piece that makes people with transplants a little bit different.
Now, Tracy, are we talking about the why behind that, or is that a question for now? Any idea why post-transplant?
It could be because of the high uric acid levels are a little bit higher in individuals that have had a transplant, but a lot of this, they don't know the why. So they look at, it could be the risk factors, and I'll talk about causes and some triggers in a second. So the simple thing with your uric acid in the middle, the simple reason as to what's going on is about 10% of the people just overproduce, they just make too much uric acid. 90% people just don't eliminate it from the body, so they're under-excreting it. Here, I put question mark, possibly dietary intake. And the reason why I put a question mark is because in the past, they've really emphasized that you should eat a low purine diet, because they said diet increases your likelihood for having a gout flare. Well, they're really backing away from that now. And if somebody's stable and hasn't had a gout flare in a while, they're actually encouraging you that you don't have to be on a restricted diet. So this is some information, and I think this is from 2009. So they looked at 405 patients that had a kidney transplant, and they were stable patients, and they wanted to look at the prevalence of having high uric acid levels. It was about 44%, and so remember across the country, everybody else, the incidence is about 1%, but it was much higher here.
Wow.
And they wanted to look at what's the association. If you have high uric acid levels, what is it associated with? Well, it's actually associated with having a decrease in your kidney function. And also, they found that people were more likely to have high triglycerides. They were likely, it was associated with the time, the longer you're out from your transplant, the more likely you're going to have your high uric acid levels, and also diuretic use. So this is a type of a study where it's kind of the chicken or the egg study. It's one of those epidemiology studies. So they're trying to look for factors. I think what it tells us is that one of the causes or one of the triggers could be diuretic use. And I'll talk shortly about how you might want to talk to your doctor about managing the diuretic medications. And also importantly, they're seeing that it can increase. In this study, it showed that the cardiovascular events, things like having a heart attack, were higher when you had a high serum uric acid level. It was 17 with high serum uric acid versus 4 with normal serum uric acid. And so this was published 2 years ago. So it's just giving us some indication that this is, having a high uric acid levels is very important. And it indicates that people really need to be followed up closely. So, the real answer is what causes gout. They don't exactly know. They're getting closer and closer every year. They really emphasized in the past that it was diet. And they told you, You want to have a purine-restricted diet. Well, purines come from things like beer, from organ meats, and actually fish, like scallops and some others. Sodas, the high, like so Coca-Cola, high fructose. Fructose is the sugar component. All of those actually increase your likelihood of a gout flare. And so there's other things in the diet that are actually protective. They found if somebody eats a lot of vitamin C or drinks non-fat or low-fat dairy products, so milk, that's low-fat dairy products. They used to say wine, stay away from wine. Well, they actually are finding out that wine really has very little effect. So they're backing off somewhat from the diet, but one advice is if someone's having acute flares and they can link it to a trigger with their gout flares, they would encourage you, these would be the target foods that you want to minimize or avoid. Now the medications. Thiazides and loop diuretics. A lot of times these are used in individuals that have a kidney transplant right after the transplant because they want to try to boost up the graft, make sure the kidney's working. And so in heart failure patients, if they're having a lot of fluid retention, they might get prescribed these medications. So it's important to look at the pattern of your gout flares. If you notice that you're having gout flare when your doses are increased or you're taking the medications on a number of days, and make that link, because it might be better to have a strategy to talk with your doctor to see if you can minimize these medications. Low dose aspirin can be a trigger. Niacin, we use niacin to treat when someone has a dyslipidemia, so if their cholesterol is high or their triglycerides are high. But on the flip side, niacin can worsen your gout. Cyclosporin and tacrolimus are the immunosuppressant medications. There's a lot of information about cyclosporin. It's pretty clear that cyclosporin can increase your uric acid level. The information with tacrolimus is sparse and it's sort of mixed. Some studies say that actually has a protective effect, and they looked at some patients that were on cyclosporin and had high uric acid levels. When they changed them over to tacrolimus, it actually lowered their uric acid levels. But on the flip side, they looked at some liver transplant patients that were taking this medication, and then it raised their uric acid levels. So sparse information here, a little conflicting, but with cyclosporin, we know that definitely is a risk factor. The other odd thing is that if you're having gout flares and you're taking medications, one group we call the uricose uric agents, such as allopurinol. And it actually dramatically lowers your uric acid levels and also causes a gout flare. So the important thing is that we know that if somebody has an acute gout flare, we have to wait until they're stable before starting medications like allopurinol. But it's just something intriguing that when the blood levels of uric acid are fluctuating and they drop rapidly, it causes a flare. I think Bob mentioned an example where trauma, if you hit your hand or hit your foot, some sort of trauma can bring on a flare. Acute illnesses like a pneumonia, a stroke, or myocardial infarction, and even surgery can bring on a flare. I first want to talk about treatment and come back to the diet. Right now, what they're really encouraging people to do is adopt a healthy diet, really focus on weight loss. And they're getting, as I said, they're getting closer to what triggers gout. They actually think it might be due to insulin, your natural insulin in your body. So if someone's overweight, your insulin is less sensitive. It's not going to work very effectively. If you lose weight, it sensitizes your insulin, so it's more effective again. So they're thinking that if you can lose weight, it actually might have a beneficial effect. And also limiting saturated fat, so butter, and then high fat milks, the regular milk. So that will be helpful. And then also alcohol, so beer, wine, and any of the hard liquors. Also, you want to adopt a healthy diet. So versus the purine restricted diet, they're really staying away from this, but they do say that if you notice that diet is a trigger, you might have to, for a time, try to restrict the seafoods and the beer. Okay, so general steps for drug therapy is that if you have repeated attacks, more than 2 attacks in a year, you might need that uric acid lowering drugs. Look at other risk factors like making sure your hypertension is treated. They discuss discontinuing cyclosporin. So you might ask, now how can we discontinue cyclosporin? So for a lot of times, situations that might not be appropriate, it's possible if someone continues to have flares, they can change to tacrolimus. There's another medication, sirolimus or Rapamune. Some studies in kidney transplant patients have found that when they changed that medication, it was effective in lowering their uric acid. The other older immunosuppressant drug is azathioprine. And in fact, studies looking at cyclosporin with prednisone versus azathioprine with prednisone showed that your uric acid levels were much lower on azathioprine. So that might be, an option to use if you're on azathioprine, another option would be to change to Cellcept or mycophenolate. That, you could avoid that.
Grace?
Yes.
While you're talking about changing from cyclosporin, one of the students asked this afternoon, I didn't have an answer for her. When somebody was on cyclosporin for a long while, what factors contribute to making a decision whether to go to Prograf or tacrolimus versus Cellcept or et cetera? And we're talking about hearts at this point.
So with the medications that we have now for the immunosuppressants, with all the advances, unfortunately, we're still dealing with a handful of medications, and so generally each center might start out with cyclosporin and the kidneys. If someone's starting to experience kidney damage, then they'll change over to the other alternative, tacrolimus. So it's always trying to manage the side effects.
How do they pick which of those to move to is really what I'm asking.
Well, cyclosporin was the older medication, and there's so much information that shows us that it's effective that's usually the first medication that's tried after surgery, and then they'll go over to tacrolimus after that. So
as opposed to Cellcept.
Well, Cellcept, you have to have the calcineurin inhibitor. So both cyclosporin and tacrolimus, they're in the class that we call the calcineurin inhibitors. So we can exchange one for the other. Cellcept is in a different category. That's our anti-proliferative agents. So they work specifically to prevent the T cells, which are involved with rejection. So they're working in a different place. So we would never replace a cyclosporin or tacrolimus with a Cellcept, but that's a good question. So there's also some protective drugs, some drugs that are used for hypertension. If anybody knows losartan, it's also called Cozar, or Allopurinol or Capsaicin. If someone is being treated for hypertension, they have a dual effect that they actually lower uric acid. So, treatment. For acute treatment, and I'll start there first and then I'll go over maintenance treatment. So for acute treatment, we have an older drug, colchicine and prednisone. They have very quick action. They'll start working in 24 to 48 hours. NSAID stands for non-steroidal anti-inflammatory drugs. For example, indomethacin or Indocin. Very effective, very potent drug. So these medications work very quickly. They do have some side effects, and I'll go over those shortly. But we do have to be careful because these non-steroidal anti-inflammatory drugs, they should be used cautiously because they can actually cause some damage to the kidneys, especially if somebody's on cyclosporin. Cyclosporin can cause some damage and they can have an additive effect. And also, people that have diabetes generally tend to also have kidney problems. So we're really concerned about the kidneys. So if you've had gout and you're not taking that medication, the indomethacin, this could be why. Another reason why, if you've had peptic ulcer or a gastritis, these can cause a lot of gastric erosion and increase your likelihood for some gastric bleeding. That's another reason why you might not be on the medication. So for maintenance, once somebody's had multiple flares, more than more than 2 to 3 flares in a year, then you need to go to some maintenance medications. And you can use colchicine, 0.6 milligrams once a day. In the old days, they would tell us, you should tell people take colchicine, take it every 2 hours until you have a side effect. That side effect is nausea, vomiting, or diarrhea. Well, we'll wipe the slate clean because they got rid of those instructions. And right now, the instructions are to take one, for an acute flare, you take 1 or 2 tablets, and then in an hour you take 1 tablet, but that's your limit for the day. So for chronic maintenance of using colchicine, we're really concerned about using 0.6 once or twice a day because this medication does have a lot of side effects. The next group are the urate lowering drugs, and that's Allopurinol, a newer drug which is febuxostat or Uric. One that's not on here is called Probenecid, and that's called a Uric drug because it gets rid of the uric acid in your urine. So these are our maintenance medications. So a couple of points. With colchicine, some of the side effects, it also can cause myopathy or muscle pain. So if somebody comes in and says, oh, my arms, I'm having some pain in my arms, that's one of the side effects. And when it's used in combination with cyclosporin, your physicians are monitoring you very closely because there is a drug interaction there, but as we know in transplant, we can't avoid drug interactions. As long as you prescribe 2 drugs together, you're always going to have the risk for drug interactions. So they manage the drug interaction between colchicine and cyclosporin very carefully. The other drug interaction is allopurinol and this medication. If somebody takes azathioprine, they should not be on these 2 medications. The medications will actually increase your blood levels of azathioprine. Azathioprine in normal doses is fine, but as a side effect, it actually can cause some serious side effects that affect your blood counts. So that's also something important. I mentioned colchicine with cyclosporin. There's a drug interaction there. There's also a drug interaction with tacrolimus. So your doctor, if you're on this medication with those 2 medications, they're going to be following you very closely. So what else can you use? Another option sometimes, instead of giving something orally, has anybody ever gotten the injection into your joint? They can use a steroid.
It hurts like the dickens too.
Okay, so there's Kenalog is the brand name, but it's triamcinolone, and sometimes they recommend the doctor would mix it up with lidocaine, which is an anesthetic. So that's an option that it works right there in the joint. It works locally, so it's not absorbed into your body, so you're less likely to have all the other side effects. But the one side effect would be just the pain of getting that injection. The one medication, Probenecid, is an older medication that helps your body eliminate the uric acid through the kidneys. But the flip side is that it can't be used in people that have poor kidney function. Now there's some drugs that are not available in the United States. There's one called benzbromarone. It's available outside the United States. That's an alternative. We did not approve it here because they're concerned about liver damage. Another product is experimental. Now, uric acid is metabolized by enzymes called uric acid oxidase. Why not just replace the enzyme? And they actually have an investigational product called resburicase, which replaces that enzyme. But still, those drugs are investigational at this point. So a few points about colchicine, because it's been around for quite a while. It's actually isolated from a plant called the autumn crocus, and I have the dosing here for the acute flare. But recently there's been a problem that was brought to our attention. Of course, when somebody went to get the prescription filled, they called in and talked to the pharmacist. The only product that's available for the next 3 years is a brand product called Colchris. And this is by URL Pharma. And the reason why this is the only product is because back in the 1962, the FDA had some regulation changes, and there were a number of drugs that were approved between 1938 and 1962. And in 1962, they had a new law. They said, we're only going to approve drugs that are proven to be effective. But at that time, they had grandfathered all these other old drugs in, including colchicine. So since the 1960s, colchicine has been used very widely, but actually there wasn't a lot of studies out that showed it was effective. So the FDA put a call out and said, hey guys and girls, we're looking at these medications and you need to show that they're effective. The one company that did come forward was Earl Pharma, and they showed that it was effective. Okay, why am I talking this? Because it's going to hurt people in the pocketbook. Right now, this is now considered a brand name product, and it costs about $5 a tablet versus cents, 20 cents or less when it was available as a generic. And so this has put a crimp in a lot of people's pocketbooks right now. It's probably going to continue until 2012, and then at that point, other generic companies will be able to come forward with new medications. Right. The newer agent that was approved about 2 years ago is febuxostat, and the brand name is Uric. Generally well tolerated. It can cause some gastric upset. It can cause a rash. And one study followed people for about 3 years, but they showed at 6 months it was some very dramatic results. So they compared the 80 milligram dose, a 120 milligram dose, and they compared it to the standard allopurinol, which we know. But at 6 months, they looked to see who had a low serum uric acid level, and about 80% of the patients getting that medication had a lower uric acid level versus the allopurinol 300. It's about 46%. So that's some good news. The other good news, in addition to affecting your blood counts, the tophi, when people have the nodules, it actually reduced the tophi as well. So this is good news because if you're on cyclosporin and tacrolimus, it's an option. If you've been on allopurinol in the past, had side effects to it, or you can't tolerate it, here's another option.
But quite often you're on, I keep calling it Imuran because it's easier to pronounce.
Oh, yeah.
So what do you do then?
Right.
I mean,
So
it's got to tell us no.
Mm-hmm. So then it's not. Then we'll have to think of some other options because of the drug interaction.
I know they've often warned us in clinic, don't use allopurinol, and now I understand why.
Yeah, because of the drug interaction. Okay. So just a couple other points with the gout flares. Knowing that lowering your uric acid levels quickly can have a flare, and with febuxostat, they show the flares, they occur pretty quickly after you start it. It was about 40%, but then by 6 months it was down to 3 to 5%. And so, what are you going to do about it? One of the things they recommend is that you need to have prescriptions at home to treat a gout flare, so make sure you talk with your doctor in advance. One combination is to use colchicine or naproxen, having that at home to treat your gout flare. And also, the advantage, in addition to the uric acid, is that these drugs also have the advantage in reducing the tophi size or the tophi size. So, if you present, or if you know somebody who has the first gout flare, and what the doctor is going to diagnose you, what they're going to tell you, though, is after the flare is over, you're going to have to wait about 4 weeks. When you're stable and everything's calm, at that point, they'll get a blood test, and they'll measure your serum uric acid level. It's only after about 4 weeks is it a good time to measure. When you have the acute flare, it's not very helpful. But with the drug therapy that we're using, I think the important thing to remember is that in addition to affecting the serum uric acid level, it has other important effects. It's trying to prevent that erosive arthritis. So it's actually having effects on your joints. Gout is associated with a decline in your kidney function, so treating the gout is really important to try to delay or stall any damage to your kidneys. And then also, once again, the tophi. It's going to cause those tophi to go away. All right. So just to summarize, I think we focused on the drug therapy, especially starting maintenance therapy when you have more than 2 flares. Adopting a healthy diet, but not being very restrictive. You don't need to have the purine restricted diet. And then if you get started on allopurinol or febuxostat for maintenance, knowing that even if you get started on it, you have a flare, continue it. Don't stop it. And remember to ask your doctor. You need to have prescriptions at home to be prepared if you have another flare, that you have to have something on hand. So, question for you. If you had a gout attack, list some descriptive terms you would use to describe the gout attack. What symptoms would you describe?
Painful.
Painful.
No. Get a little bit higher.
I'll start with that. That's the first thing you notice, man. Then you're looking for redness and so forth.
Excruciating.
Yeah, okay. Oh, I see what you meant.
So, and, you know, if you put a bed sheet over it, you know, ouch, you know, it's very sensitive.
And it doesn't go away quickly.
It doesn't go away. And so, you know, for, you know, if you're talking, I know a lot of people here talk with other people that are newly transplanted individuals. You know, one of the things that you're doing if you're coaching people is, you know, getting them to think about what their pain is like. And with gout, there's a couple of different patterns here. You can have intermittent pain where you're no pain and then the red blocks mean that you have these intermittent episodes. That pretty much describes gout. But encouraging people to think about what their symptoms are and the pattern of the symptoms. And this is a resource that I got from a site called painfoundation.org. And they really encourage people to keep a diary of their symptoms. And then, here's an example where they use a pain score of 0 to 10, where, you know, somebody, you know, on this day, they would mark off 6, meaning 10 is the most pain they've experienced and 0 is no pain. And then every day they mark down their symptoms. They can bring that into their visit, and then the transplant coordinator can go over it with you, and you can give the healthcare professionals a better idea of exactly what you're experiencing. So really nice resource from this website. Okay. All right, so the second half of the presentation, I just wanted to go over diabetes and talk about 2 problems that stem from diabetes that also affect foot care. And start with a little quiz. People with borderline diabetes don't have true diabetes.
False.
Okay. Eating sugary foods does not cause diabetes.
True.
True.
People who take insulin have severe diabetes.
In most cases, true.
Okay. So there's probably for both of these, it's sort of a true-false. The one thing I think is important with diabetes is to know that diabetes is diagnosed when your blood sugars, a fasting blood sugar is greater than 126 milligrams per deciliter. Our students at the Philadelphia College of Pharmacy, they go out in the community and they screen, they'll do random blood sugars. If, you know, a random blood sugar means it's taken without regard to being fasting or you might have eaten. If at any time your blood sugar is over 200 milligrams per deciliter, you have diabetes. So there really is a little trick question, because the important thing is there's really nothing such as borderline diabetes. So if someone has diabetes and your blood sugars are elevated, it really is important because your risks are going to be higher for the 2 problems we're going to talk about, the diabetic foot and also peripheral neuropathy. The eating sugary foods does not cause diabetes, and that's true. However, remember that sugars are a carbohydrate, and eating too many carbohydrates means you're eating too many calories, which leads to being overweight, which is a cause of diabetes. So diet is going to come into play when we talk about management. And then finally, people who take insulin have severe diabetes. I thought this was important to talk about because there's a change. Doctors and other healthcare professionals who prescribe medications, there's a change. They really want to follow your hemoglobin A1C, so you might go get a blood test. And they may try you on oral medications first, but if they don't get the response, don't be surprised if you do get started on insulin. Or if you're coaching someone, talking to somebody, be reassuring with them that, it's important to get your hemoglobin A1Cs down below 7. So they're not waiting a long time anymore. They're really being aggressive and starting insulin, but it's a good thing. Okay. So the diabetes causes problems to big organs like the heart, to the kidneys, and that's why we wrote down nephropathy or kidney damage. It also causes problems to little blood vessels like retinopathy, eye damage. The leading cause of blindness in the United States is from diabetes. Peripheral neuropathy is nerve damage. And then subsequently you also get some foot problems as well. Okay. So ulcers that occur on the feet, it can occur on the ball of the foot, under the big toe, or even on the side of the feet. And if you have ulcers on your feet, you're more at risk for infections. If you have an open ulcer for more than 30 days, you're at risk for having osteomyelitis. If you've had some trauma to your foot as well, that can also increase your risk for serious infections. And also if you have peripheral vascular disease. You know, in the United States we talk a lot about heart attacks, myocardial infarctions. So I think you might know from the television commercials that they show the coronary artery and they show the plaque, the fats that accumulate, and they close off the blood supply. Well, the same thing can happen in your legs. You can get peripheral vascular disease affecting the arteries in your legs, and it decreases the blood flow to your legs. So once again, another reason that peripheral vascular disease or peripheral artery disease is another reason why you're likely to have a problem. And the complications are serious. So the American Dietetic Association recommends everybody gets an ankle foot exam. There's also a very simple, non-invasive test, doesn't hurt, and it's called an ankle brachial index, and they just measure the blood pressure around your foot and then compare it to your regular blood pressure, and that tells you if you're going to be prone to peripheral artery disease. And they do also recommend that you see a podiatrist or an orthopedic surgeon, someone who's an expert in foot ulcers if you do have an ulcer. So the reason why you really want to be aggressive and with this is that non-healing diabetic foot ulcers lead to amputations, and if you have had an amputation, 50% of patients are likely to die in 5 years. And so this one factor, people having routine foot care, getting a comprehensive into a program, reduces the rates dramatically. So a couple of points for treatment. There's a number of non-pharmacologic things we can do, like wearing compression stockings. That helps the blood flow. Now I'm sure in the summer months, it's probably not the most comfortable thing to put on your legs. The screening, the monofilament screening, if anybody's had that, it's just a thin wire that they run down your foot. And in diabetes, you can lose the sensitivity to your nerve fibers. And what happens if you lost that sensitivity, if you put on a shoe and there's something rough in it, you might not feel it. So it might cause an ulcer. So that's why this monofilament exam is really important. And a few years ago, I went on a vacation with one of my friends, and she has diabetes, and she told me before we went, she said, oh, I'm wearing my old sneakers, because she didn't want to get a new pair of sneakers that might rub up against her feet and cause an ulcer. So she was really careful. And also, self-care is the big term that we use in healthcare. It simply means that people are involved in their own care, checking their feet, getting a mirror, making sure they look on the bottom of their feet to make sure they don't have any ulcers. And my friend had said, she was going over the instructions that her doctor told her, and every night she would always put lotion on her feet to make sure that she would keep her feet smooth. Okay. Now there's some things out there, people are concerned about infection. For prevention, things that don't work, things like antiseptics, like betadine. You wouldn't want to put that on your skin. It doesn't really work if it's given preventively. Topical antibiotics aren't really effective either. The only time antibiotics are really recommended in diabetic foot is if you're actually treating a real infection. Some other things, they have some fibroblast growth factors, these little growth factors which they'll put on some ulcer tissue, and it helps promote healing. One product is Regranix. Hyperbaric oxygen going into the hyperbaric chambers. The oxygen actually works as an anti-infective. It kills bacteria, and the oxygen getting to the tissue helps the tissue regenerate again. And then, of course, for more serious situations, peripheral vascular revascularization, there are vascular surgeons, that's their specialty, and they will do procedures called angioplasty. They'll go down and they'll open up those blood vessels. So I want to stop here for a second. Does anybody have any examples of anything that you've ever heard of, any other products? This is a troublesome area, so a lot of times there's some complementary and alternative medications.
The stockings work the best.
The stockings, okay.
I sold them for 25 years for Joe's.
Oh, okay.
And it all has to do with the hydrostatic column.
Mm-hmm.
The more pressure you put there, the more fluid's going to be going through.
Mm-hmm.
And all the doctors, all the vascular surgeons would say that the stockings are the best.
Mm-hmm. Stockings are the best, and no side effects. And so, when you're standing during the day, you get that dependent edema, meaning that gravity pushes everything down and people will have swollen ankles, but the stockings help get everything circulated. There's one unusual product, it's called Medi Honey, and I thought I would share that with you. And they've done some research in honey is a sugar. Sugar is actually acidic, so there's a special, it's a pharmaceutical product, and they actually apply it to the ulcers, and that sugar causes an acid environment and actually promotes healing, and people have found that they need less dressing changes if they're trying to clean their wound. So a little unusual product. Okay. So another important thing as a pharmacist in a number of states, including Pennsylvania, pharmacists can now immunize, and so I wanted to put a plug in to make sure that you want to prevent other serious infections, viral infections like influenza. So if you have a diabetic foot ulcer, which could potentially be infected, you want to try to prevent. Influenza is a viral infection that puts you at risk for other bacterial infections. If you've had a transplant and you're on immunosuppressant drugs, by now you probably know that you can't get Flumis, the nasal spray, because that's a live virus. You would have to get the trivalent inactivated virus vaccine. You can also, to prevent infections, you can get the pneumonia vaccine. And also, remember, quit smoking, because smoking actually affects your blood flow to your tissues as well. All right, so what are some steps you might take on a daily basis? So if you're talking to somebody who was concerned over diabetic foot, what might you tell them to do? We have one suggestion, use compression stockings. How about for care, any other?
Skin moisturizers?
Skin moisturizers.
Don't walk around without some kind of foot cover.
Exactly. Don't walk around barefoot. Okay. Anything else?
You have to self-educate yourself.
Mm-hmm.
You have to look.
Mm-hmm.
You have
Yes.
to look.
Mm-hmm.
That's all.
Keep screen. I don't know. I didn't put my enter key, but I think all good points that you made. And one other little tip is just be careful with hot and cold. If somebody wants to put a heating pad on their foot, not a good idea. Could hurt. In doing some research, I did find this group. I don't know if anybody has heard of this group before. Save a Leg, Save a Life Foundation. It's developed by a podiatrist, a doctor of podiatric medicine, called Dr. Desmond Bell. It's affiliated with the American Diabetes Association, and it's a new professional organization. And I included their website here in case you want to do some more research with that group. Okay, so diabetic foot is a serious problem. What can lead to it, and what is a separate problem, is diabetic peripheral neuropathy. So I'll finish up with this information today. And in our central nervous system, we've got our brain and our spinal cord. That's the central system. But then everything going out, all the nerves going out to the rest of your body, your skin, your muscle, your organs, that's your peripheral nervous system. And those nerve fibers can get damaged by diabetes. And the way they normally work, they send signals. It's like a little train with the caboose and the different train cars. each nerve cell is sending a signal to the next nerve cell. And one of the substances is called substance P. The P stands for pain. And that's why acetaminophen or Tylenol is so effective, because it inhibits that substance P. So in addition to sending out signals, some of the nerve fibers, when they're damaged, they can also cause some painful symptoms. So here's an example of the brain, and the spinal cord is the central nervous system. But in the periphery, this is the snapshot or a slice of the spinal column. So the nerve cells go out to your muscle. So at the part where the nerve muscle meets the muscle, the nerve cell meets the muscle, that's called the neuromuscular junction. And that can get damaged. If someone has diabetes, that can get damaged. So a couple of important points with diabetes, the neuropathy is a chronic pain syndrome. So anytime the symptoms occur beyond 3 to 6 months, someone's complaining of leg pain or pain in their hands, that's a serious problem. Another important term is diabetic sensory motor polyneuropathy. It's a mouthful. It's another scientific term, but it means the same thing. And when someone has the pain symptoms and they find that they're intensively controlling their blood sugars, they'll actually find that those symptoms will go away. And in people that do have diabetes, about 3 to 25% are actually going to experience the peripheral diabetic neuropathy. So these symptoms are problematic if you're talking to somebody and you're counseling them on this. Ask them questions like, how does it affect you? Is it affecting your sleep? Does it affect your willingness to get up out of the bed in the morning? Does it interfere with things like doing your laundry or going grocery shopping or doing the lawn? Because this is a chronic problem that can have a significant negative impact on individuals, and many people actually develop depression because of this problem. Okay. So if you've had a transplant and you've developed diabetes, you are at risk for diabetic peripheral neuropathy. And the metabolism of glucose, this is the accumulation of end products of glucose metabolism. They're causing some damage to the nerves. They're also affecting blood vessels, and they're impairing blood flow into the tissues, and they're actually causing nerve damage. So in addition to the neuropathy, we also see problems with the eyes and with the kidneys, and also you're at increase for your cardiovascular problem. So one of the things that they did, they evaluated over 100 patients, and they followed them at 5 years, and they took a look and they wanted to see, is there anything we can do to try to affect the damage? And they actually showed if they dropped their hemoglobin A1C by about 1%, so if they were at 8, they brought it down to 7, they actually did show that they improved some nerve function. So I thought that was some new information that was published in 2010, and I'd like to share that because it shows that with some aggressive treatment you can have an effect. Now the symptoms are symmetrical. It's going to happen on both sides of the body, the right and left side. And these are some of the terms that people use to describe the pain. And the prevalence of peripheral neuropathy, I put the scale down here. So this would be 0 to 15%. Diabetic patients, it's about 13%. If you have impaired glucose tolerance, about 8%. If you have impaired fasting glucose, meaning your blood sugars, you're not at the point where you have diabetes, but your blood sugars are slightly elevated, it's 4.2%. And then individuals without diabetes that have normal blood sugars, it's about 1.2%. So the purpose of this slide is just to show you that as you have poorly controlled blood sugars, your likelihood of having these symptoms is going to be increased. Okay. So Dr. Ziegler, I got this from Dr. Ziegler performed a study. He surveyed some patients and asked them, where are you having these symptoms? And most of the people said it's the feet, 96%, and in these different areas. About 40% said it actually affected their calves as well. 40% said they had symptoms in their hands. So it's quite troublesome. And this came from a website called painedu.org, pain education. And so once again, we're dealing with a disease that has a lot of symptoms. there's really no objective measure. You can't go in to get a test and say, oh, you've got about a 50% peripheral neuropathy. So you're really relying on the patient to tell you what they're feeling. And this is only part of the page, but this website has a lot of different pain scales that if you're counseling somebody, you could talk to them, have them print it out. And so here, please use the scale below to tell us how sharp your pain feels. And they would just rate it. So over time, they could track that and they could bring that in. There are some, the neurologists or the specialists that would care for the patients, and they can do nerve conduction studies. And so they'll be looking at the nerve conduction study in addition to symptoms to make the diagnosis. And actually, they can see the nerve damage first before someone actually has any symptoms. And so the symptoms, in addition to the painful symptoms, it causes a loss in just sensation. If somebody's touching the bottom of your foot with a wire, you're not going to feel it. And also it can affect reflexes. So it might affect your ability to walk. So the neuropathy, it's pain symptoms. There's a lot of other conditions that cause similar symptoms. So it is important to talk with the doctor and see if you have a complicated case, see a neurologist so they can help diagnose and make the differential diagnosis. I'll point out there's some drug-induced causes like alcohol use can cause the problem. Individuals that have had cancer that have chemotherapy or also radiation therapy, they can also get a peripheral neuropathy. Right, so question and answer. What areas of the body are most frequently affected with pain symptoms? Is it A, one side of the body, either the left or right? B, both feet? Or C, both hands? And the answer is B. Okay. So this is, the majority of people it is affecting the feet. And it's challenging for all of us because sometimes you might have medical problems and you're not the classic textbook. And so just to make everybody feel better, what I'm describing, the signs and symptoms tonight, are really the true classic textbook problems. And sometimes people can have progressive worsening. Sometimes people can have an intermittent presentation, and they're called atypical presentations. But the majority of the time, people are going to complain about problems with their feet. There are some non-pharmacologic things you can do, like distraction therapy. And I use this when, at the college, we participated in the immunizing our pharmacy students. They would come in for their flu vaccinations, and so the first time I did it, before I would even give them their injection, they're jittery and they're jumping, they don't want to be there. So the next time I wised up and I brought in some pictures of some movies that were out and some other pictures. So when they sat down, I'd be talking to them and like, hey, have you seen these movies? Are you going to go out with your friends and see movies? And they'd start to talk to me about what they're going to go see. They didn't see me back here getting my injection ready. So by the time I was done giving them the shot, they forgot about it. That's distraction therapy. So, if this is a problem for someone that perhaps talking, there's many pain centers available that might use some of these things. Assistive devices, it's pain in your feet, perhaps using canes. Exercise can help. Physical therapists might use some heat and cold therapies. And then there's the transcutaneous electrical nerve stimulation, or the TENS units, which they give you some electrical stimulation which sort of overrides those pain symptoms. So you feel something, but it doesn't cause pain. Right, the drug therapy, I first wanted to start with the approach to the drug therapy, and I'll point out there's some first-line drugs, there's some second-line alternatives if the first ones don't work, and there's some third-line therapy that can be added on. And with the different medications, I put the different drug classes, the drug name and the brand name. So the first tier drugs are up here at the top. Amitriptyline is an older drug which was actually used to treat depression, and it's pretty much the most effective drug that's out there. If you treat 2 people with this medication, or let me say it this way, if you treat 100 patients with this medication, about 50% are going to get a 50% reduction in their pain symptoms. So it's pretty effective. The other medications, duloxetine, which is Cymbalta, pregabalin, which is Lyrica, and then gabapentin, which is Neurontin, they're fairly close in effectiveness. If you treat 100 people, about 25% are going to get a reduction in their pain symptoms. And these are averages. Everybody has a different response. There's a topical agent called capsaicin. It's derived from red pepper, and it burns. So when you put it on your skin or on your feet or legs, it'll burn. And it's a counter-irritant. So eventually it will stop the pain symptoms that you're having. And it's available as Zostrix or Capsaicin Key. So that's something a little bit different. It's not ingested, it's topical on your skin. And then finally, those third-line agents, which often are used in combination with the others, are from the opioid class. And these are drugs that are strictly for pain control, Tramadol or Ultram, and oxycodone or Percocet. And these medications, they're called control drugs. From the pharmacist's perspective, we have to get a written prescription from the doctor, and we can't refill that prescription. So they are under control. So for all the medications, the top ones, as I mentioned, are fairly effective. And there's a little theme running through all of them. You know, this tiredness, dizziness, duloxetine, sleepy, pregabalin, sleepy, gabapentin, sleepy. So, you know, if you have a job where you need to be out during the day, that can be a problem. Now, if you have insomnia and you take these at night, that's actually the benefit to them. Some of these medications also treat depression, so you can get double duty on them as well. The Capsaicin Cream doesn't cause the sleepiness, but it's used to 8 weeks because it works well in the short term, but it can also, with prolonged use, it can cause some problems. And it's a touchy medication. When you're applying it, you have to wash it off right away. And if anybody ever is experiencing some persistent burning or itching, you do want to call the doctor. That's the problem with that medication. The opioids, like the Ultram, they can also cause some tiredness, and a lot of people also complain about constipation as well. So there's some newer treatments. Tapentadol stands for longer acting or extended release, and that was studied, and it's shown to be more effective than a placebo. Tramadol or Ultram was shown to be used in combination with acetaminophen, that's Tylenol. And they titrated up to 3 tablets a day, and that was as effective as the gabapentin, which is also called Neurontin. And the tapentadol is called Nucynta, and it's a controlled medication. So once again, with the approach to treatment, it's just helpful that your physicians and prescribers have a lot of different medications to use. There's a product available in Europe, it's called lipoic acid, and it's actually an antioxidant. They didn't approve it here because the FDA didn't feel it was effective, but there are some things available outside this country. So as a pharmacist, if someone has a medical need for a medication, it's important from us to encourage them to get the appropriate treatment. But a lot of times people are concerned when they use drugs like the Ultram and the Percocet, they're concerned that it does cause a physical dependence. And what that means is that over time, the longer you're on it, we might have to adjust your dose, we might have to increase your dose. Now, some people get overly concerned, and they're concerned about addiction. Addiction means that somebody has drug-seeking behavior. They're going to go rob a car to steal money to get drugs. And honestly, when somebody has a medical need for these medications, the percentage of people that actually develop addiction is minuscule. That's not really our concern. But we do know that there's a physical dependence that comes. You might have to use a higher dose, and you never want to stop these medications abruptly. And I'm really referring to drugs like the Ultram and the oxycodone and this new agent. We have to titrate down. The other problem is they can cause some sleepiness and drowsiness, so be careful because you don't want to mix it with alcohol drinks. And then my final recommendation is to go back to encourage that diary because it's helpful to know when you're getting the symptoms, and then if you've used any medications to treat it, we call those rescue medications. So if somebody comes into their doctor and has this diary filled out, it just helps everybody help you better. Right, so here's a question and answer. Which drug is the best choice if you have to drive a car each day?
D.
E.
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 So answer is E, the capsaicin. And so I think the good news here is that there's a number of different options. So if I always like to talk to people to find out, do you work outside the home? I don't always assume that everybody's working during the day, because some people work during the night. And another thing is if somebody has a need to be out during the day where all these other drugs can cause a lot of sleepiness, then there's this one option that doesn't cause that. Another thing is lidocaine patch. There's a 5% lidocaine patch. You can put it on the area that's effective, and you put it on for 12 hours and then take it off for 12 hours. That's another topical product that's used.
But it's expensive.
It's expensive, yes. So I just wanted to finish up with letting you know there's a lot of different healthcare professionals can help you. We talked about our transplant specialists for foot care, podiatry, neurologists have an expertise for the peripheral neuropathy. And I just wanted to inform everyone about pharmacy. And there is a changing paradigm. When I graduated from school the first time, in the 1980s, I graduated with my Bachelor of Science, and it was a 5-year program. But currently in 2011, pharmacists are in school for 6 years. Many pharmacists, if you talk to them, they will have had a 1-year residency program. A number will go on for a 2nd year. They actually specialize. Some do specialize in transplant pharmacotherapy. And many pharmacists are board certified. And also in many states, practically all, I think now, we are licensed to immunize. We get our license. So I encourage everybody to ask a pharmacist. You might be surprised if you're having problems with medications, or if you have questions about lifestyle changes or problems with your symptoms, ask a pharmacist. Because pharmacists are very knowledgeable. They probably know more than you think they do. And they're in the community, especially your community pharmacists. You don't have to make an appointment to see a pharmacist. You just have to walk in and talk to them. They're there and they're accessible. Thank you, everyone, for your attention. I'll stop here, and if anyone has any questions, I'll be happy to have questions or we can discuss anything.
Yeah, you mentioned something about increasing the opiates.
Yes.
Wouldn't that be dangerous to increase it as opposed to decreasing it?
So let's use an example of the oxycodone. When it's used in combination with acetaminophen or Tylenol, we call that Percocet. And with these medications, that you do need to be followed and managed carefully. When they titrate up on the medications, then every time you have a dose increase, you'd be concerned about side effects like sleepiness, tiredness. If anybody takes these medications, it can cause some confusion, and that's a signal that, oh, the dose is too high, we're going to have to titrate down. So what's important from the doctor's perspective is that if you're on this medication, they'll give you a prescription, but they're going to want to see you again. They're not going to send you away, go away, come back in a year. You're not going to hear that. They're going to want to come in and want to follow you.
They'll give you a 30 or 60-day prescription.
So is that for someone who would, I'm sorry, Steve had his hand up.
Go ahead.
Is that for someone who would take that every day as opposed to someone who would take Percocet for a migraine headache when it comes on?
Well, with the peripheral neuropathy, there's a couple of different approaches. In the one study that they talked about patients that use the tramadol or Ultram with acetaminophen, they were taking it every day. So that is a possibility. Another approach is to take the medications like the amitriptyline or duloxetine and intermittently use some other medications for those days that are really a problem.
What are your feelings about medical marijuana?
Well, medical marijuana for nausea, for treating nausea.
For pain.
For pain. Well, I know, I haven't done too much research in that area. I know for treating nausea, that it's been shown to be effective.
I have a friend that is in the process of probably losing his leg for diabetes, because of diabetes. And he's been on medical marijuana for the last 6-8 months, and he says it's wonderful. What are your feelings about using medical marijuana for pain instead of these drugs?
Well, if it's, the one concern I have is just the perception, especially for the young people in the country. We have a lot of young people that are abusing medications. They're abusing alcohol. So my first reaction is always that, is it sending the wrong message? But in addition, we have individuals that have severe problems. They have pain that might not respond to the traditional medications, and if they don't get the effect, or they're having significant side effects with the other medications, I think under the appropriate circumstances, that it could be, if your friend is having a good response, that's wonderful to hear.
Are you aware that there's going to be opening up clinics in New Jersey for medical marijuana?
Well, the last thing I heard was that Governor Christie was not going to approve it. So.
And you also have to understand marijuana is a drug, because a lot of the drugs come from, not marijuana, but come from plants. And that's what it is, a plant.
It's a plant.
So you call it a drug, no matter how you want to slice it.
And it does have its side effects, so, if somebody were driving in the car next to me, and I hope that they are taking their medication, their medical marijuana, either at night when they're not driving, because it does have its side effects as well.
The same as the other medications like oxycodone and the rest of them. So it's 6 of one, half a dozen of another, basically, right?
Yep. They'll have the sleepiness and the tiredness.
Is it my understanding that no one really knows what causes gout? I mean, you have all these theories and everything, but you can't pinpoint.
You can't. And I did go over a lot of examples of things that might trigger it. And for example, trauma, if you injure your arm or your foot. But there's a lot of times when there is no trigger, that people will experience a gout flare, and they, looking back at what were they doing before, they can't find a trigger. So there's still that element, we don't know exactly what's triggering and what the cause is.
I know this much. I shouldn't have, but I ate herring, and within the next day, I had a flare.
Okay.
A big one. I'm not eating that again.
So you have to know your triggers.
Sometimes it's individualized too. Like, any time that I have beef followed by something with mushrooms, I have that issue. And I think it depends on your own body.
I remember, I forget what I had originally, but I knew it wasn't gout because I read on the internet how they would put a needle in your joint to determine what it was. So I didn't have gout. And we would treat for this. What was it, Pam? Do you remember? It started with a C.
Cellulitis.
Cellulitis. And we cure it. And so I had cellulitis until one time it wouldn't go away. And when I went to a podiatrist, he said, "You got gout." I said, "No, I don't. You're not going to do that." "No, heck, I give you a pill, it's gone in 2 hours." What? I've been hobbling around all week and you could do that? So between colchicine and indomethacin, it went away. And I came back to see him the following week. I said, "Whoa, what did you do to my arthritis?" I said, "I'm walking around like a youngster again." He said, "Oh, well, that's the anti-inflammatory." I said, "Can I take that?" I mean, I was getting to the point where I was crippled. And he said, "Yeah, sure, no problem." I said, "Really?" I knew that was not a valid answer, but I wanted to hear that. And so I said, "Can you prescribe that?" "Sure." So I got a 90-day supply of 2 a day type thing. And I went to my family doctor and I asked him about it, because I checked with family cardiologist nurse, and she said, "It's going to kill you." I said, it's killing me now if I can't move. And so I went to the family doctor. He said, not a problem as long as you have blood work done to watch the kidney function. I said, well, I have that done every 6 months down and out. He said, that's good enough. And so I tapered down from the 2 a day to eventually, when it got bad enough, take 1, I'm good for 3 or 4 days. And so sometimes I take it twice a month maybe. So then when I got down to the heart people, of course, that doctor got very concerned about anything ending in CINE. I don't know what that's about, but I said, listen, doc. And so I've got a committee. So far, the committee is 3 in favor, 2 against. And I can move, and I'm the swaying vote on this. So I'm afraid to ask you, because I don't want to lose my mobility. I mean, I got to the point where you had the Synvis shot, and they did the x-rays, and you got no cartilage left. That's your problem. But with indomethacin on an ad hoc basis, I can live. And so from what I've heard, I understand what you're saying, and I got to watch it carefully, and I don't want to take it regularly, but it is something that makes mobility at least possible.
So would a knee replacement?
Not going to do that one if I can avoid it, but anyway.
What's your uric acid level?
My normal is about 7.6. And so we've watched that too. And last time I ran into gout, it was, shrimp one day, shrimp the next day, and had to have lobster over lunch. And so it wasn't a surprise the following week.
Start hanging out for lunch with you. It's a bologna sandwich any day.
So anyway, it's been an interesting experience, but it's gout, and it hasn't happened frequently, but I used to, typical guy thing, right? You sort of ignore it's going to go away. Well, after 5 days, you were limping and on crutches, it wasn't going away. And then once this doctor could show me you could get rid of it in a couple hours, I felt like a fool treating myself, of course, through the doctor. But it matches what you're telling us here. I just learned a lot from this, so thank you very much.
You're welcome.
And the chart of 1 to 10, it has to go higher than that.
Although I don't know whether that hurt more or when they stopped the needle it hurt more.
Does anybody else have any other questions, not just related to the feet? I mean, we're talking about pharmacists here. You've got her dedicated attention. She's very good. Bernard?
Just go over the peripheral nephrology. As soon as I hear the word peripheral, right away I'm confused. I think of being able to see. My peripheral vision. My peripheral vision is impaired. It's got to be part of this, and just to repeat a little on how it affects the eyes. The glaucoma is the big problem, but so is the peripheral. My bottom quarter is gone. I can't see my face.
Right. With diabetes and the glucose or blood sugar metabolism, it damages the retina, and so people will complain of blurry vision, and it does lead to more serious problems. So
Again, that's part of the diabetes.
part of the diabetes,
But tell me, controlling the diabetes to a point that can actually help your vision. Yeah. It doesn't sound too good, but that's...
You need to be seeing an ophthalmologist every 6 months.
I am,
Good.
but my problem is that it's cords.
Yep.
It's the cords. And it doesn't matter how much they can fix it or try, whatever. It's how it got there in the first place.
I've also found, I think from conversation with people in this room, that there are these medical specialists, and there's these medical specialists who are familiar with transplant.
Yeah.
And so typically the transplant programs refer you to doctors, they refer a lot of people to who are experienced with the transplant uniqueness of some of the things we deal with. And that does make a difference. I can honestly say that.
And I would, just congratulate everybody. I know a couple of people in the room, and the importance of coming back for the follow-up. And there's for some people, that don't get the message. From time to time, I've met some individuals that have a new diagnosis of heart failure, and they come in and they get their treatment and they think that's it, and they don't realize that's just the beginning. And they go away, and we might see them in 2 years, and they're much, much worse. So I think, in talking about all these medications and all these terrible side effects that happen, I think everybody here realizes it's, we try to watch everybody carefully, and we try to catch things, and if we see someone's having a problem related to the medication, then they're always considering alternatives and making adjustments. So that follow-up is really important.
And the other thing is, we're always getting a year older each year, and then even if you didn't have a transplant, we'd have some of these problems, right? Grace, I want to thank you on behalf of Transplant Recipients International Organization to invite you and sponsor this meeting, and give you a little gift to say thank you. I really appreciate your coming and helping us understand what we're all going through, right?
Thank you.